syndrome. So it's a progressive, non-inflammatory, it's a degenerative disease, non-inflammatory disease, it's a degenerative disease. It's combined with generalized neuromuscular weakness, just as myasthenia gravis, okay? But it's not autoimmune. And in most of these cases, we do have esophageal dysfunction. And I just, as a gastroenterologist, and not as an endoscopist, I really want to highlight something here. Whenever we're talking about esophageal dysfunction, this doesn't mean that we're going to have findings, radiographic findings of megaesophagus. Because when we have what we say functional megaesophagus, which means esophageal dysfunction, this might not be visible in a plain lateral radiograph. So we really have to proceed on to doing the contrast studies in order to diagnose the esophageal dysfunction and the esophageal hypomotility in these cases. So when a case comes that the owners persist, or the referring veterinarians, if you're a referral clinic, persist that this dog has regurgitations, and you have a lateral, you just make a lateral thoracic x-ray and nothing shows there, please do not exclude esophageal hypomotility. Not unless you perform the contrast radiograph. So this is why, because I might have, some questions might rise, why do I distinguish between esophageal dysfunction and megaesophagus? Isn't megaesophagus an esophageal dysfunction? Yes, it is, but there are other forms as well. So many of these dogs with gulp syndrome continue to exhibit weakness and exercise intolerance past Tyvek surgery. These animals were diagnosed with laryngeal paralysis. They had the Tyvek surgery, yet no improvement was actually noticed after the surgery. And not only that, during the first year of their follow-up, they tended to progress into other neurological deficits. And these animals, unfortunately, have a very poor prognosis. So this is the study that Michigan State University did. We're not going to stay long onto that, but I wanted you to be aware of that because this is a very, it's a new syndrome, even though it is reported since 2010, as you see in the vet surgery. Not many of us know about it, and we actually misdiagnosed it, and we misdiagnosed it as myasthenia gravis or something else. So the study included 32 dogs that already had a Tyvek surgery, and they wanted to compare the esophageal function in these dogs with idiopathic laryngeal paralysis to age and breed match controls, and to determine if the dysfunction was associated with aspiration pneumonia. Let's go to the conclusions, which are really interesting. So the dogs with the gulp syndrome all had they had laryngeal paralysis combined with esophageal dysfunction. That's one thing to keep in mind. And also post-operative aspiration pneumonia is more likely in dogs with higher dysmotility esophageal scores, which is only normal. If the esophagus does not work properly, then I might have a higher risk of aspiration pneumonia. And dogs with this syndrome during the next year after the Tyvek surgery might develop generalized neuropathy. So it's a disease with a very poor prognosis. Let's go now to our field, which is the diagnosis. And it might seem very simple to you to perform a laryngoscopy, which is actually it is, but we have to know the step-by-step procedure in order to be able to, and certain that we do have laryngeal paralysis indeed, and it's not an artifact. Okay, so the best way to diagnose laryngeal paralysis is the direct videoscopic, the endoscopic observation of the larynx under light general anesthesia. And here comes, you know, all the troubles. What is light general anesthesia, and how can it affect the laryngeal movements? When do I check the larynx? During induction or when they wake up? There are two schools in that. I actually, 2 to 3 weeks ago, I attended a webinar on laryngeal paralysis by a very pronounced endoscopist. And they said that in the States, they do it during induction. In Europe, they might do it during when the animal is recovering from the anesthesia. So both are right. Okay, and let's see what we watch when we have laryngeal paralysis. We have paradoxical laryngeal movements, and I'm going to show you, of course, in videos what we mean about paradoxical laryngeal movements. So in inhalation, narrowing. If you remember, in inhalation, the rima glottidis, which is the gap between the two vocal folds, must stay open so that the air goes into the lungs. Instead of that, in inhalation, we have a narrowing of the rima glottidis as a result either of a negative pressure caused by the airflow through the narrow laryngeal ostium, okay, due to the Bernoulli effect. And during the exhalation, the opening of the rima glottidis, we have an opening of the rima glottidis instead of closure, okay, due to air pressure. Other diagnostic tools to diagnose laryngeal paralysis is EMG in dogs as young as 12 weeks if you have this modality. We don't have it, and I have no experience with electromyography. Ultrasonography, which is called echolaryngography, and transnasal laryngoscopy. And there was actually a research paper comparing these three techniques, which is the direct transoral observation, the ultrasonography, and the transnasal laryngoscopy. And the ultrasound could not diagnose half of the cases. It was a very poor modality compared to the transoral observation and the transnasal laryngoscopy. Between those two, between the transoral, so the ultrasound was very poor, had very low sensitivity. Between now the transoral observation, the direct observation, and the transnasal laryngoscopy, there was no significant difference in the accurate diagnosis of laryngeal paralysis. But if you have transnasal laryngoscopy, it's a much harder procedure to perform. If the rate of diagnosis is exactly the same, why not prefer to do the transoral observation? So we tend to do the transoral observation and the transoral endoscopy because it's easier for our patients. And of course, we cannot omit all the other steps to diagnose the underlying, any other underlying disease. We definitely perform hematology. For example, we might have anemia, non-regenerative anemia in hypothyroidism, or elevated white blood cells. And this might lead us to an infection. Biochemistry, because we might have, for example, an elevated alkaline phosphatase or hypercholesterolemia that might lead us to hypothyroidism or any other, or elevated CK, creatinine kinase, which might lead us to myasthenia gravis. We always check the thyroid function, not with simple measurements of a serum T4, and I really want to be very strict on that, because we have this sick euthyroid syndrome that we tend to neglect sometimes, and not every animal with low T4 has hypothyroidism, okay? Because due to the sick euthyroid syndrome, we have animals that have any other forms of any other disease and have low T4. For example, if an animal is on cortisone, it will have lower T4 levels. So we tend to do all of these examinations, a very comprehensive thyroid profile with free with measurements of T4, free T4, and of course, I would love to actually highlight here that the free T4 should be measured with equilibrium dialysis. This is the preferred way of measuring the T4, CTSH, and of course the antibodies. Never neglect the antibodies, because all the others might be normal, and the antibodies might actually indicate thyroiditis. Okay. The acetylcholine receptor antibody titers for diagnosing myasthenia gravis, the anti-2M antibodies for masticatory myositis, and of course, thoracic radiographs to rule out aspiration pneumonia, megaesophagus if detected, okay? And for esophageal dysfunction, we said that we also need contrast studies. So what are our goals for laryngeal examination? First, we check all the structures, the cartilages, here, the arytenoids, the cartilages, the vocal folds, okay? If we have the mucosa should be pink, and all the superficial vessels, just as here. Can you see the vessels here? All the vessels visible. No proliferations, no thickening of the epiglottis or the arytenoids. To check if there is any secretions or edema or ulceration, any proliferation like webbing or granulomas or neoplastic tissue, and of course, the motion. This is what we check with the laryngeal exam, the evaluation of the arytenoid movement. So a lot of us talk about which is the ideal anesthetic protocol. And this is a very crucial matter in the laryngeal exam. So the ideal anesthetic protocol is to maintain intact the laryngeal reflexes while achieving such an anesthetic depth to allow the jaw relaxation. Once the jaw is relaxed, this is the ideal anesthetic protocol. And of course, this is very challenging because even with light anesthesia, sometimes this may result to apnea or swallow inspirations, and this will actually make our diagnosis harder. So before making a laryngeal examination, get ready, which means have everything handy and beside you. Use a laryngoscope with a long blade, not a short one, because you might not be able to visualize what you want to see. Have handy mouth gags, the ET tubes, because you might have to intubate the animal. It would be wise to have an endoscope. I always do, either a rigid one or a flexible one. Capture your video because this might add value to your examination. This is what you're selling to your to the clients, to your owners, and of course a detailed report. This is not an examination that, you know, even if it's for 10 minutes, it's a very valuable examination for the animal, and it should be considered as all the other endoscopic procedures. So give value to what you're doing. And this has nothing to do with laryngoscopy session actually, but give value to what you're doing with a detailed report, with videos, or with photographs, captures, because this will actually strengthen the compliance rate of the owners. When you give them something, then whatever you say, for example, a tieback surgery or a medication, you will see that these clients will comply better if they have everything in their hands, all the information in their hands. Okay, and of course, have an anesthesia monitoring. Let's go now to the most controversial part of the examination, which is the sedation protocol. There have been a lot of studies. One of them actually used either for pre-medication azithromycin or butorphanol, and this is what we actually do as well. And for sedation, aflatoxin or propofol, we tend to use propofol in our clinic. And as a respiratory stimulant, doxapram. So Neither propofol nor eflaloxone alone resulted in reliable arytenoid motion, either before or after doxapram, which is a good thing. And this is another paper on the effects of doxapram on laryngeal function, because a lot of people are afraid of using doxapram. It is true that as a referral clinic, we tend to have a lot of laryngeal paralysis cases that are so obvious that we do not need doxapram stimulation in order to diagnose laryngeal paralysis in dogs. So sometimes we omit the step of doxapram administration. And some of the papers out there, either review papers, are made without doxapram administration. So let's talk a bit about doxapram. It's a central nervous stimulant that increases actually the respiratory rate, and it acts within 30 seconds of administration. Some questions that I know that you might have: will it make an abnormal larynx work normally? No, it will not. Okay, in a normal manner. So doxapram will not intervene in the function of the larynx. It will override the potential depressant effects of anesthesia, which means that if the larynx appears abnormal before doxapram, if I am an endoscopist and I have used my sedation protocol and I see a larynx that I'm not sure, does it have paresis, does it have paralysis or not, or is it normal and my sedation was not that light, was a bit higher than it should be, then if the larynx appears abnormal, then we use doxapram and it gives us the solution and the diagnosis. If the larynx appears abnormal before doxapram and functions normally after doxapram administration, then it's normal. It was due to your sedation, the effect that the image that the larynx looked as in paralysis, as in laryngeal paralysis. So this is a situation that doxapram would actually be very helpful. So it also can stimulate respiration by reflex activation. So be aware and be ready to intubate these animals. Okay. And this is why we say that the administration in normal dogs results in increased respiratory effort and death. And then the administration to dogs with laryngeal paralysis may actually trigger paradoxical motion of the arytenoids due to inward motion of the weakened arytenoids. And be prepared, if you give doxapram, be prepared in these patients to intubate. So our plan is in these patients to always pre-oxygenate, okay? And we can either give or not pre-medication. I rarely do, unless the anesthesiologist says that we should give butorphanol, for example, and we mostly use butorphanol. I mostly do most of my laryngoscopy examination with plain propofol. And we check the larynx, and if necessary, you can give after that the respiratory stimulant. Here is a normal larynx, and you can see we have symmetrical after doxapram administration, of course. This is after doxapram administration, okay. The arytenoids open, thin and tight. Can you see the thin and tight vocal cords? Straight. The submucosal capillaries are visible and no secretions here in the epiglottis. Let's see here an abnormal larynx. The asymmetrical arytenoid abduction, they cannot be abducted, okay? And we have thickened and flaccid, these are the flaccid parts of the cords. There are elements of inflammation here. The capillaries are not easily visible because of the inflammation and the edema here in these areas and here as well. We have mucosal hyperemia and a few secretions in the vocal, in the epiglottis here, in the epiglottic area here. Okay, and now let's go to the most valuable and most interesting part of the presentation, the cases. So we have Labrador, 7 years old, female spayed, and the primary complaint is exercise intolerance and labored breathing. And the breathing was actually estimated by a video that the owner has sent us, and it was this one here. Open mouth breathing. We have stridor. I have a lot of other videos of Millie, so we could actually assess that it was a stridor, but I'm gonna let you hear a bit. Hypercyalosis and tealism every 2 or 3 seconds. Gagging and retching, coughing that was after the gagging. Okay, the gagging preceded the coughing. Regurgitations, an inspiratory stridor, dysphagia. She left parts of her food in the water bowl, small parts, because she could not apprehend and chew the food properly. Change in barking. And during the neuro exam, she also had weakness with proprioceptive deficits. And for the past 5 months, she has been on doxycycline and rofloxacin, maropitan for the regurgitations, probably, or the vomitings, aminophylline, because some of our colleagues might have misperceived that this was a lower respiratory tract disease, prednisolone, unfortunately, and ranitidine as a prokinetic for the esophagus or for the vomiting episodes. But there has been no clinical improvement and progressive deterioration. So on clinical examination, we had a heart rate of 102 with strong pulse, mucous membranes hyperemic. The capillary refill time was 1 second, not normal at all. The respiratory rate was 67 breaths per minute. And of course, we had hyperthermia, either hyperthermia or that was true fever. And you can only assess that after you keep the animal under monitoring and observation, and after you go through all the other blood work to see if the animal is truly febrile or hyperthermic. Mild dehydration, of course, we had abnormal lung sounds, really high-pitched wheezes, highly probable due to aspiration pneumonia. So the blood work yielded neutrophilic leukocytosis with a regenerative left shift, monocytosis, an elevated HCT, probably due to dehydration, a marked increase in alkaline phosphatase and hypercholesterolemia. The CK was fourfold up. Your CK, even in your neuro patients, the patients that have some kind of myasthenia, not your neuro patients, I'm sorry, might be normal sometimes. So don't be fooled by a normal CK. It comes pathological in only 50% of the cases. So you have to, if you have a suspicion of a muscular disease, you have to proceed in other diagnostic procedures in order to verify it and exclude it. And of course, all the infectious diseases were performed, leishmaniosis, Ehrlichia. We as Mediterranean countries, we tend to have a lot of that. Borrelia, Bartonella Hensley, that I know that you don't test dogs for Bartonella Hensley, but Bridesford, the hematologist from the university, said that we have a lot of animals with Bartonella Hensley, that dogs with Bartonellosis that have, vague symptoms and symptoms like that, like they're febrile, they have thrombocytopenias, and we definitely have to check them. And once I started checking the dogs for Bartonella henslei, a lot of them come positive. So toxoplasmosis, everything though in this dog came out negative. So we have an increased alkaline phosphatase and high cholesterol levels and a CK that's 4 folds up, and a CRP, which is actually an inflammation marker, was markedly increased as well. Let's go and have a look at the plain lateral thoracic radiographs. As you can see here, we have some air in the esophagus and here, but no visible megaesophagus whatsoever. And we have a mild interstitial here pattern in the left caudal lobe. I know that aspiration, most of us know that aspiration pneumonia is visible in the middle lung lobe, but in the right middle lung lobe, but sometimes you might have, if you see the papers on aspiration pneumonia, sometimes it might surprise us and go to the caudal lobes as well. So we did, of course, a barium contrast study, and as you can see now, the esophageal dysfunction is visible. There is a clear esophageal dysmotility in this animal, a functional megaesophagus. So that was 10 days after the antibiotic treatment that she got, because she had elevated white blood cells count. We performed, as you can see here, the lungs are better. And 10 days after, we did the barium contrast study. Of course, there's always the danger of you causing aspiration pneumonia in these patients. So be really cautious, but you really have to somehow verify if there is or if there is not an esophageal dysmotility. And of course, we proceeded with monitoring of other specific diseases. You can see how she was admitted on what the clinical signs were on admittance. This is a collapsed dog, actually, that cannot move, cannot breathe. It's obvious that has a respiratory distress. And in this video, I can tell that maybe it's cyanotic. Okay, so we did an acetylcholine receptor antibody titer, and it came out positive for myasthenia gravis. The thyroid profile was negative, and also the anti-2M muscle fiber antibodies were negative. So we have the laryngoscopy here. As you can see, we have thickened arytenoids with mucosal hyperemia, the movement of a lot of excretions in the epiglottic area that go into the trachea.
Melih Hanım, sesimi duyabiliyorsunuz. Kıyafetiniz mikrofonunu tutuyor galiba. Düzeltebilir misiniz?
Let's go to the...
Konuşmayın lütfen. Sesiniz gidiyor yayına. Şu an iyi.
And this is also the mucosal edema here. No movements of the larynx whatsoever. Paralyzed larynx. And of course, the tie-back surgery, we're not going to go into surgical involvement. The tie-back surgery is the gold standard, and I'm going to leave that to the surgeons. So the definite diagnosis of Millie was LP on grounds of myasthenia gravis, and she got mestinon, lansoprazole, which is a PPI inhibitor. It's a PPI medication for actually the esophagitis that this dog had, and the reflux esophagitis, because she had an hypomotility of the whole gastrointestinal tract. So a lot of the gastric contents were coming as a reflux disease into the esophagus. Sulfate and a low-fat diet. Let's go to the second one. This is Pico, a Rhodesian Ridgeback. This could be perceived as reverse sneezing, but it's stridor. It's inspiratory stridor. This dog is in respiratory distress. So this is a Rhodesian Ridgeback, 11 years old, male spayed, and it came on admittance with exercise intolerance and labored breathing, reverse sneezing, change in phonation, tyolism, showed here, and orthopnea. You're going to see some other videos of Pico as well. You can see that he stays in orthopnoic posture. He cannot move. He just stands there with the neck extended and does some tyolism. And the owners thought that this was a case of having inflammation in the larynx, and they have tended to use ice in order to alleviate his symptoms, but the poor guy could not breathe. He was sleeping, standing like this. Let's go into the hematology quickly. Neutrophilic leukocytosis, again, regenerative left shift. We had inflammation, monocytosis, a marked increase in alkaline phosphatase, high cholesterol levels, CRP, which was increased as well, negative all the infectious diseases. The CK was normal in Pico, the thyroid profile normal, and the acetylcholine antibodies were negative. CT scan. We had some multiple hepatic nodules, a splenic nodule here, and a focal atelectasis in the right caudal lung lobe. Nothing else. He performed a total body scan. Let's go into his laryngoscopy. You can see that he has these flaccid vocal folds and a paradoxical movement that are moving paradoxically, edema in this area here. Let's go to the other video as well. How much time do I have left? Let's see what time it is so that I cannot. Okay, we have time. The paradoxical movement, again, more obvious. And the rima glottidis, as you can see, very stenotic in this animal. So the diagnosis was made out of exclusion. And you might ask me why it was the GOLD syndrome. Why did this animal have high cholesterol levels and high alkaline phosphatase? Because it's a geriatric patient. Alkaline phosphatase could be out of other reasons elevated. For example, the bile or the bile duct disease, or the prostate gland disease, or bone, something that had to do with his bones, but osteoarthritis, but it needed more investigation in this area. Okay, the third case, Cotton, very quickly, gagging, retching, 6 years old, spayed, change in phonation. They all have the same symptoms, dyspnea, tyolism. Let's hear it. This was a very severe case, and thanks to the surgeons, Dr. Durdas in our clinic, you will see the results later, and Dr. Tota, the anesthesiologist. As you can see, the stridor and the inspiratory effort is dreadful. The poor animal could not stand up. And this is the high-pitched sound of the stridor that I was talking about. This is not lower respiratory tract. Okay. The X-ray was this, which is unremarkable. Increased alkaline phosphatase and cholesterol levels, mild non-regenerative anemia as well. The T4 levels and the free T4 low, the CTH increased. It's, you know, a direct diagnosis of hypothyroidism. And let's see the laryngoscopy. there is this thickening of the arytenoids here. And because due to this thickening and the edema down here, you can visualize some of the vessels, but not all of them, especially here, and no movement. There's some edema up here as well. And secretions in the ventral part of the epiglottis. And this is 2 weeks post-op. Cotton had a lot of names because she was adopted. She was a stray animal and she was taken care of. And after the operation, she was adopted, actually, to a home. But you will see that she's running without any respiratory discomfort. Okay. And this is a real severe case that was admitted to our clinic. A Pomeranian cross, 9 years old, and you can see the high-pitched sound of respiratory distress. And of course, this dog had temporary tracheostomy. We couldn't do otherwise. So what do we do with these patients? No diagnostics. You cannot handle these patients to perform x-rays or to perform radiographic examinations or anything else. You just try to stabilize these patients. And how do you stabilize them? You put them in a cool environment, in an oxygen cage, IV fluids, mindful, of course, you should be mindful of the pulmonary edema. Sedation, sometimes we have to sedate these animals due to the respiratory efforts that they're having. Some anti-inflammatory drugs, and of course, temporary tracheostomy. And this is a negative prognostic indicator. If an animal needs to be alleviated by tracheostomy, this means that the disease, even if there's any other underlying disease, is not manageable anymore. It's end-stage disease. Okay, and this is what laryngeal collapse looks like. You can see that the rheumatoid is not existing at all. Let's now differentiate, and this is what I actually wanted you to take as a tip home, between the differentiation between laryngeal paralysis and laryngeal collapse. The laryngeal collapse is secondary to chronic upper airway obstruction, like the dogs that have the brachycephalic syndrome. It's considered an end-stage disease, and patients can do well with medical treatment, but only in mild or moderate forms, and the more severe require surgery. And of course, alleviating all the symptoms with tracheostomy if needed. There are a lot of grades in laryngeal collapse. The first one is the eversion of the laryngeal saccules. So for grade 1 laryngeal collapse is spotted here, is detected here in the eversion of laryngeal saccules. Stage 2 in the median displacement or paradoxical motion of the cuneiform processes down here. And then the third stage disease is the collapse of the corniculate processes. I'm gonna show you, this happens in the brachycephalic airway syndrome, part of which is the laryngeal collapse. Not the laryngeal paralysis. The laryngeal collapse is a part of the Boas syndrome. What are everted saccules? You can see them here. These are the everted saccules. Do we treat them? There was this paper that came out that said that if you correct the nares, if you correct the soft palate, sometimes the surgeons do not correct the everted saccules in the brachycephalic dogs, but they tend to monitor them over time and correct them later if they persist, because it seems that when you correct the elongated soft palate and the stenotic nares, then the saccules come back to normal in time. And the last case, and this was, you know, a bit funny, just to give you a laugh and some rest. A Doberman pincher, 9 years old, that came with cyanosis and respiratory distress, and it was perceived as laryngeal paralysis. Let's see the laryngoscopy here. And as you can see, there is this metal object. It was not laryngeal paralysis, but a metal object was embedded, was lodged in the rima glottis. A foreign body embedded in the larynx. And what was this foreign body? It was an earring, because he tended to lick the ear of his owner. Okay, so when you think it's LP or laryngeal collapse, but it's not, it's laryngeal foreign body. And this is the earring of the owner, which was really funny, but not so funny for the poor dog. Thank you very much for your attention. I think that I'm not over time. I'm 10 minutes overdue. And before closing this session and giving the speech to the organizers, I would like to tell you that during this challenging COVID era, we have the time to focus on the vital. I know that these are hard times for everyone. But these are the times also to focus on the vital few, which are our families, our personal development. And we all get the brain that we earn, not the brain that we want. So practice and allow yourself to make mistakes, because experience is what you get when you don't get what you want. Stay healthy and safe.